Good evening, everyone, and welcome to our Q&A session on the COVID-19 pandemic. We are streaming live from the Jawaharlal Nehru Center for Advanced Scientific Research in Bangalore, and the objective of this session is to answer some of the questions that the people have about the COVID-19 pandemic. Joining us today is noted Indian Virologist Prof. Udaykumar Ranga and the Vice President of the AFPI, Karnataka, Dr. Ramakrishna Prasad. Thank you, gentlemen, for agreeing to be a part of this. I'd like to begin, if I may, with a question that has both a medical as well as a scientific aspect to it. This second wave of the pandemic has hit us.
Introduction to what we are doing, what we are not doing.
And then maybe later. So the question that I have is, this second wave has hit us really bad. And we know that one aspect of it is because of our own, lax attitude towards it. But is there something different about the virus itself? Is it a different strain, or why is it that this one is so much more worse than the previous one?
So, I think you want to go?
No, Dr. Ranga, why don't you?
Okay, this question is very difficult to answer because what we know is very little about this virus at this point of time. We know a little about its genetic sequences, mutations, variations in certain regions of the virus. But we do not know whether these mutations have really any consequence to either evolution or pathogenesis or infectivity. Those data are yet to emerge. That will take several years. But definitely, the number one. Number two, we do not know how other environmental factors, right, other supportive systems are functioning. For instance, I may have been infected with the same virus. One time I have very good medical support. But next time I did not have medical support. I don't have oxygen, I don't have bed, I don't have this, I don't have medicines. So the first time I was saved because of medical support, but next time I may not be saved. So death rate in both the cases, as far as you know, is the same. There is no much difference. But the numbers are very large in the second epidemic because we have assumed that we have won the virus during the first wave. That is a very serious mistake actually, and that is the reason people were complacent. They thought the virus was over and they were too careless, at multiple levels. That gave an opportunity for the virus to spread further. Any virus, especially RNA viruses, when they are proliferating, they accumulate lots of variations, mutations as they are moving on. Therefore, you are going to see differences in the viral genetic context between one peak versus next peak. But how much these variations really contribute to any of these biological properties, pathogenesis, we are yet to understand this.
Sir, from a medical perspective, what is different that you see in terms of symptoms or pathogenesis as compared to the previous wave and this one?
Thanks, Arun. I think just to add to what Professor Udaykumar said, any outbreak has to be looked through the lens of agent, host, and the environment. And there are multiple things which are different about the second wave, which compared to the first wave. I completely agree with Professor Ranga. I don't think we clearly know whether the mutants or whether the variants are biologically that much different in terms of pathogenesis. There are indications that they might be more transmissible, they might be more virulent, certain forms. But we also, I think, as a practicing physician, I particularly think of this from a health systems point of view. The large number of deaths that we have seen, most of them, in my direct experience, have been because of the inability to recognize early, access interventions which clearly prevent death early, and having the health system support. For example, if there is a person who needs steroids, and we know that steroids can help, but say that is never recognized in a timely manner, then that person does not have access to that. Or if there is a person whose oxygen is falling, but there are no beds, there is no access to oxygen, then obviously that is going to drive mortality, that is going to drive fear, that is going to drive adverse outcomes. So I think it has to be looked through the lens of not just the virus, but also the host and the and the system. And I particularly agree with Professor Ranga. One of the things is just sheer numbers. India has a population of 1.3 billion people. And even a significant but small percentage of the Indian population, when it gets infected, that translates to enormous numbers, which very quickly overwhelms our healthcare system. So that's what I think is happening.
Sir, we keep hearing of these new strains of the virus that are emerging. There's a UK strain, South Africa, there's now an Indian strain. But this should be a common phenomenon across viruses, right? Is it true that all viruses, given time, will ultimately become more and more pathogenic with time? Polio, smallpox, everything?
You're talking about pathogenicity.
Yes, pathogenicity
versus
yes.
Evolution. Actually, the opposite happens. Any virus, any pathogenic organism, when it starts, especially if it is a new pathogenic organism, in the initial phase, it is going to be extraordinarily or highly pathogenic, killer. But that is counterintuitive or counterproductive because it is a parasite. By eliminating the host, the parasite is going to eliminate itself. Therefore, there is always a selection that takes place. The virus or the bacterium has to down-regulate or reduce its pathogenic level to that extent that it is not too dangerous or too virulent to a given host. It cannot become completely friendly, non-pathogenic at all because it is a pathogenic organism to start with. So it will be remain pathogenic, but when it starts very high pathogenicity, that has to moderate pathogenicity. This happens to every single pathogenic organism. So with evolution, all pathogenic organisms will not become completely less harmful, but they are going to come to moderate pathogenicity. That has to happen.
Okay. Sir, one thing that is really disturbing in this wave is, as you already mentioned, the sheer numbers, the lack of hospital beds, and is there something that the people can do to buy time for the patient until such time that something that can be done at home to so that they can just buy time until hospital bed becomes available?
Sure. I think the question you asked constitutes the most useful information I actually might be able to present. If I could request that slide number 5 and 6 be presented. Actually, you can leave it at this slide. I think it's really important for people to understand the following.
If you want to point.
Sure. I think it's really important for people to understand. This is from the All India Institute of Medical Sciences guideline, but it's very important for people to understand that the majority of people who get COVID-19 do not end up with a crisis. It is very important for people to understand. It is very important for people to understand that the majority of people who get COVID need not panic. But it is of critical importance to be able to recognize some of the danger signs. If you can go to the next slide. Next slide, please. This is basically what is happening inside the body. When someone gets exposed to the virus, there is an incubation period which would be of several days. But once infection sets in, the virus starts multiplying. We can clearly see that there are 3 different phases to this infection. In the first phase, which is typically the first week of infection, we think of this as the viral phase. In the viral phase, the most common symptoms are fever. People can have tiredness, they can have body aches, muscle aches, they can also have some burning sensation around the eyes. But it is important to know that though there is fever, most people do not die in this phase. This is not where most of the crises happen. A few groups, like people with asthma, etc., need to be careful because they can have an asthma exacerbation or flare up where they develop wheezing. They need to be careful in the first phase. Many times, around the beginning of the second week, around day 7, day 8, day 9, this is when many people whose fever actually might be subsiding, they start experiencing certain symptoms like increased difficulty in breathing. Sometimes it could even be as subtle as difficulty in speaking. A common thing I sometimes hear from patients is, I was able to speak very comfortably on the phone yesterday, but it looks like even speaking on the phone is making me breathless. These are symptoms which should not be ignored. By recognizing that these are actually symptoms which indicate that the amount that the percentage of the lung which is able to function normally is going down, we can initiate certain forms of certain interventions, the most useful of which is to initiate a steroid. Can we go to the next slide, please? Next slide, please. Yes, I want you to please keep an eye on some of these things. Number one, feeling shortness of breath, not being able to speak, like I said. If you are talking to somebody and you find them not being able to speak in full sentences, or you notice that their nose is flaring, these are all signs, or they appear to be wheezing. These are signs to look out for. If they complain of loose motion, especially significant loose motion around the 7th day, 8th day, these are signs, these are symptoms to be taken quite seriously. If they appear to be confused or agitated, or they're not able to eat or drink, or experience extreme fatigue, where they tell you, doctor, I have not been able to get out of bed today. These are things to be taken very seriously. Next slide, please. A few things which can help buy time to come to your question is, number one, recognition that this is a problem. Number two, lying down prone. Prone means lying on your belly. What this does is it allows the lungs to expand further. And many times that brings up the oxygen level. If you have access to a steroid, now most people without a history of asthma usually have never used a meter dose inhaler. And this requires some coordination between squeezing and you inhaling. So it's sometimes difficult to teach someone how to do that. But oral steroids, like a tablet, this is something most people can easily consume at home. So many times we give them a prescription, but remember, steroids are double-edged swords. You cannot give steroids to everybody. You cannot give it prematurely. It actually does more harm than good. And then in the recent past, we've been hearing about mucormycosis, which is linked with steroid use. But steroids, when used at the right time, can definitely buy time. So oral steroids. The other thing we can do is, if say somebody has an inhaler, you can teach them how to make a spacer. A spacer is actually like a bottle like this, where you can cut a hole, put the meter dose in the inhaler, and this helps people breathe at their own pace. Access to oxygen, if it can be arranged while a bed is being found, that is also something which buys time. In the recent past, though, things seem to be improving in the last few days. This was a major problem. Oxygen cylinders were not available. Oxygen concentrators were not available. So primarily using proning and steroids. I think this is what we were doing to buy time, because the average duration to get into a hospital bed, at least in Bangalore city, about 2 weeks back, would range anywhere between 12 to 24 hours.
Sir, there seems to be an acute shortage of drugs that specifically target, this coronavirus. We have Remdesivir, but that was not really developed for, the coronavirus. It was originally developed for hepatitis C, then they used it for Ebola, and then now we're using it for, the SARS-CoV-2. So two-part question, one to Professor Ranga. Why is it that, we don't have something, despite, a year and a half into the pandemic, we don't have something that targets this virus directly, a drug? And Dr. RK, to you does Remdesivir actually work? Professor Ranga, if you go for it.
See, any viral, antiviral. See, vaccine is not antiviral. Vaccine is the one which teaches your body to develop immune response. The immune response your body is developing against a specific virus, right? But A drug, when you say antiviral, it's a chemical, a drug that can actually block viral, most likely some of the enzymes of the virus or virus attachment to the target cell. It's a small chemical molecule. It can reach all the body parts and interfere with the viral cell cycle or virus cycle, its proliferation. Now, to develop a thing like this, you have to have several laboratories to work extensively for several years, right? That needs high throughput screening, developing such assays and screening large number of molecules and developing their analogs using chemistry experts and then doing clinical trials. All this will take at least 10 years, right? If you are talking about Remdesivir and many other viruses, viral antivirals, a molecule which is good against one virus is not likely to work against a different virus. It's like, keys, which opens one lock is not likely to open a different lock. But why people are trying this? That is desperation. We don't have antivirals to corona, SARS corona. So people are thinking, because this antiviral is working against this, this virus effectively, hopefully it might work against corona. But actually, ideally speaking, there is no such antiviral agent that really works. But Dr. Ramakrishna Prasad will elaborate on that one. But many labs are at this time working on developing antivirals to SARS-2, but that will take time. The virus has all the advantage to spread at very rapid rate, but we cannot promote science to that extent and cut short the vaccine, all this research necessary to identify such molecules. Definitely, scientists will identify many more molecules, and all this will be available to us to fight the coming future coronavirus infections. But right now, we do not have them. There are many scientists are working. Problem two is this virus cannot be cultured in regular laboratories. It requires high containment laboratories. Level 3 laboratories are required. There are very few of them in the world, right? You cannot handle this virus in level 2 laboratories. So therefore, that is another serious constraint. If only this virus can be handled in a level 2 laboratory, many more laboratories, many more scientists will come to this area, and this process will be rapidified. But even with this, it will take at least 5 to 10 years from today.
Arun, I have a slide. If slide number 14, slide number 15 can be projected. That's good. That's good. Thank you. Right. Okay. So no, I completely agree with Professor Ranga. It's not easy or possible to change the timeline for innovation, and especially innovation which can translate into practice with evidence in such a short time frame. I think, but I will say that there have been multiple attempts all over the world to repurpose. What already exists can be used. That in fact, Professor Ranga and I had recently been to CDRI in Lucknow, where they had repurposed Umifenavir, an antiviral, and they had done some clinical trials to look at the efficacy and safety. Data, of course, is awaited. So you asked me about Remdesivir. Now, the issue at the next slide, please. I have a specific slide on Remdesivir. Right. So Remdesivir has obviously been a very controversial drug. It has evoked a very strong response from multiple people. The fact is, even for observation to show a certain pattern, it takes time. I think it is fairly clear now, I would say, that Remdesivir per se does not seem to alter clinical outcomes that matter to patients. What does that mean? So when in clinical evidence, we look at two levels of evidence. One level of evidence is called a POEM, patient-oriented evidence that matters. The biggest thing that matters to patients is, does giving a drug save more people? Does it save them? It looks like Remdesivir at this point has no data to support a mortality benefit. The second is, does initiation of Remdesivir prevent something like hospitalization? because hospitalization is a very traumatic, catastrophic event. In fact, in India, the largest number of people who become bankrupt and go below the poverty line is because of catastrophic costs related to healthcare. Remdesivir being an injectable drug, it's not something you can use it at home and in other settings. What the data does show that in lab studies, remdesivir acts on the virus. There is also some data to indicate that it might reduce the duration of stay in a hospital. So we have to, in a pandemic where information is rapidly emerging, rapidly evolving, information is asymmetrical, there can be misinformation, no one has very clear signals. But at this time, I think remdesivir has a fairly limited role. Limited role, but as a clinician, sometimes it's hard to not use whatever tools, especially in situations of crisis, that may be available. But that would be my comment.
Okay. Sir, the next question is about the real-time PCR test, the RT-PCR test. It's called the gold standard for detection, but why is it that a lot of times, despite having an RT-PCR, I mean, the patient would be COVID positive, but the RT-PCR would test negative. So why does that happen? I mean, if this is the gold standard, why can't we do something better?
There are 100 different reasons why this can happen. Right? It's not just one or two, there are multiple reasons. Starting from the biology of the virus itself. You have to understand, if you can visualize a viral proliferation, Dr. Ramakrishna has shown previously. The virus, when it is growing, initially it is very low, it grows to a peak, and then it again vanishes. Right now, when I sample, what phase of this peak phase, this graph and sampling is very important for me. Suppose if I sample them very early on, there is not much virus at that time. Or alternatively, if I sample at the end of this phase, viral phase, again I don't have much sample here. Right? That is problem one. That means for my PCR to work effectively, I need to sample it when the virus is at the highest point. Problem one. Problem two. Where do I collect this virus from? Where is the virus actually proliferated into the early phase? It is mostly in the upper respiratory tract, or maybe later in the lower respiratory tract. Right? If I do not really go there, if I do not really collect that one, and if I don't suspend properly, or if I don't store the sample properly, the transportation, processing, all this matters. Right? In the sample, it's not just the virus RNA alone, there are multiple other RNAs available. So how well these people who are actually doing this work, this job, are trained also matters. Do they really know how to really do this RT-PCR is one important aspect. And add to that, how good is this PCR? Are these primers well designed? Are they really effective? Have they been tested very well? That matters. And the other thing is genetic variation of the virus, right? Viruses is changing. The primers which are designed to amplify the viral genome sequence, if there is one small mutation at a very critical position of this primer, that will significantly reduce the effectivity of this PCR. So there are many large number of questions. For instance, when I'm processing, if there are contaminants that also co-elute with the RNA sample that can inhibit my PCR, that can matter. So there will be 100 different reasons why something happens. So we cannot simply say this is the reason, this is not the reason. Right? So it needs thorough examination and to understand why that RT-PCR fails. So anything, your car works, but if there is no petrol, however expensive car, however good car, it won't work. There is a basic flaw. There is no engine, there is no petrol in the car. Right? So RT-PCR can fail for multiple reasons, not on RT-PCR. Any technical fail if you do not know how to do it.
Just to add to that, completely agree with Dr. Ranga. From this is RT-PCR is a great example of efficacy meeting effectiveness. What that means is, something that works in a laboratory, when it meets the real world, there are several other challenges that come up. So just to provide a clinical perspective, we saw in the curve, for example, that typically by the end of the first week, the amount of virus being shed goes down. So then the sampling time, when do you sample a patient? That actually has an influence on the likelihood of whether your RT-PCR comes positive or negative. Second, how well has the sampling been done? You know, there's a, I'm part of a lab which has been doing RT-PCR since August. And we find that there are several samples which depend on the technique of the swabber, because the swabber has to collect enough cells from the back of the throat or from the nasopharynx because for the test to be positive, because you cannot actually. The third is transportation. Just imagine a public health program, for example, the municipalities collecting samples. Now, you know, they have to batch collect and then they have to deliver it to a lab. Sometimes there can be a delay, and legitimate delay. This is not a time to criticize the good work they are doing, but there can be a legitimate delay of several hours. Has the sample been stored properly? Has the sample been labeled properly? Has the sample been closed properly? Was it taken at a certain temperature? We in India definitely live with very high temperatures in many parts of the country. And then processing time within a lab. So, and as Dr. Ranga pointed out, you know, technique of whether you're doing whether you're doing bead extraction or column extraction, all this has an influence, which ultimately influences the field sensitivity, not the efficacy, but the field sensitivity and specificity of PCR testing. And from a clinical point of view, a clinician uses the same numbers to estimate what is called positive predictive value, negative predictive value. For example, if a patient comes to me, he has fever, he has body aches, and in his household there were 3 other people who had COVID. You know, to me, the pre-test probability, even before I do the test, I expect the test to be positive. So when the PCR test, if it comes back negative, as a clinician, I'm not going to call this not COVID. You know, so these are some things we need to keep in mind as far as interpretation. One health systems implication was till very recently in several cities, including in Bangalore, it was difficult to get a BU number, which is a number which the municipality gives to facilitate admission to a hospital if the PCR test was not positive. This was a very problematic thing for patients and families and doctors, because you know a patient is having breathlessness. You know clinically this sounds like COVID, looks like COVID, smells like COVID, and is being treated like COVID, but you cannot find a bed because the BU number. So thankfully, the administration has now revised the criteria for issuing a BU number and made provision for a clinical classification or a clinical definition to get a BU number. That has been a very welcome move.
So the take-home message is, if your RT-PCR is negative but you have mild fever or something, there's no guarantee that that you don't have COVID. You should still isolate,
Yes.
And you should still take all the precautions that is necessary,
Yes.
even if your RT-PCR does come back negative.
In a time like this, a time of a pandemic, any respiratory viral infection, any influenza-like illness. For example, what I mean by that is anybody presenting with fever, cough, sore throat, body aches should be considered as COVID until proven otherwise.
Okay. So while we are on the subject of RT-PCR, how do we interpret this CT value that the labs give us?
Yeah. So here I have a schematic to explain what is CT value. It is a little bit confusing because the relation between the PCR result and the disease outcome are just negatively correlated. Means when my virus is very low, I need a very high CT value. Right? When my virus is very high to start with, my CT value is going to be smaller. So that means that is because of this relationship. How do you get a okay here? Is it laser?
Yeah, he's just getting it.
Yeah. What I have shown you, just
Go back.
Yeah, that's fine. Here, what I have shown here is, there are two regions here. Okay, here is very little bit of virus in the sample. I cannot see that, because if I can see that, I don't need RT-PCR to do. What is PCR doing? It is actually whatever little virus is present in the sample, it is amplifying, increasing. In every cycle, it is expected to double. If I originally have 100, in the second cycle, I will have 200, a small region of the virus. In the second cycle, I have 400. Like every time, it is increasing the viral copy number, so that here you can see that if I start with a very small quantity at 0, when I start my assay, 0 cycles, that is what I cannot see that. After 5 cycles, the viral copy number increased in my assay, but still I cannot see. After 10 cycles, it still increased the signal, but still I cannot see. 15 further increase, I cannot see. But after 20 cycles, now it has come into my zone of visualization. Now I can see it. Right? After that, whether it increases or not, less important to me. The first cycle of my assay, what I see is my CT value. Here it is. Therefore, I call it, for this sample, my CT value is 20, because that is when I see the first time. It could be 19, it could be 18. I haven't shown those examples, but they are there. When I jump from 15 to 20, 15, 16, 17, every cycle, the number of viral copies increased in my reaction queue. Right? So here I started with very little bit of RNA in my sample, but I needed 20 cycles so that I can see the signal as positive. Therefore, I call it my CT value is 20. Now, what would happen if my original sample, RNA sample, is a little higher? Here it is. I have more virus to start with. Because I have already more virus, now I don't have to start at this 0 level. My 0 level is starting here. That is where I am, right? So after 5 cycles, my RNA increased, our copy number increased. 10 cycles it further. Now, by the time I reach 15 CT value, I can see the result as positive. Previously, I needed 20 cycles because I started with very small amount of RNA, so that I needed 20 cycles to see it. But here, within 15 cycles, I can see my result, because my original RNA is much higher. Therefore, my CT value is 15 now. That means the correlation here is, when I have originally more virus, I need less CT value. Therefore, there is early detection. In other words, when CT value is less, means there was more virus. When there is CT value high, means originally there is less virus. What happens to a sample that has no virus? Next, here it is. Let us say I have a sample, there is no virus at all, it's clean. There will be no amplification. I will not see even after 40 cycles anything. So it is a negative sample. I will never see even after 100. I mean, nobody does anything more than 40 cycles of amplification. 40 is the highest, but anything about 35 is really not reliable. So this is the relationship. There, because it is an inverse correlation, when you have more, you need less cycles. When you have less virus, you need more CT value. Because of this inverse correlation, it is a bit confusing, but not for people who are in the field. So if I know that a patient has 25 cycles CT value, means compared to another guy who is 10 cycle, I know that that 10 cycle guy must be having much higher virus. But again, we cannot directly interpret this like this. That is very important. Okay, this can be very misleading, the CT value. All I take the CT value as is as a presence of virus. Whether that CT value is 15 or 20 makes no difference to me. Both are positive. That all I have to take it. I cannot say that this 15 CT value has more virus than 20 CT value. As I mentioned previously, there could be many other reasons why that difference happens. Sampling, the amount of RNA present in the process sample, the primers design, there are 100 different that can make this difference. So you can never ever compare two people and say this guy is he is at higher risk than this guy. There is no such correlation. All that matters for me is the CT value, ideally speaking, between somewhere below 30 or below 35 or above 35. That all matters, nothing more matters.
just to add a clinical perspective to this, um, before the COVID pandemic, 80% of doctors probably had never ordered an RT-PCR. But now, in most cities, more than 80% of the population has used this word RT-PCR, and the CT value has become actually it sometimes is used as a tool for a lot of fear mongering and things like that. So I want to make 4 points as a clinician. The first is that there is a lot of variation and no standardization between CT values depending on the kit you use and depending on the stage or natural history or the time point at which you collect the sample. Number one. Number two, CT value has not been shown to have any correlation with disease severity. This is a very important point because there is another score which also is called CT severity score, but that is something you get a score after doing a high resolution CT scan, computerized tomography. But CT value, sometimes people get confused between this. This CT value reported on an RT-PCR report has no correlation with disease severity. Number three, ICMR came out with guidelines recently, maybe about 2 months back, saying use the cutoff point as 35, as Professor Ranga pointed out. Otherwise, different kits used to have different reporting criteria as to what you called as a positive and what you called as a negative, and this used to cause a lot of discomfort in a lab, because you could sometimes you had a CT value of 39. And you don't know, is it really true virus? Is it a false positive? But the clinical and social implications are huge. Someone with a positive RT-PCR report may not be able to go back to their apartment. If they are living in an old age home, they may be asked to leave that old age home. If they need social support, they may be asked to isolate, which is actually traumatic psychologically. The fourth point is, CT value tells you about the viral RNA, not necessarily the virus. Because people will ask you, obviously in society or in the community, the concern is about infectiousness. So one of the problems with RT-PCR is that though the virus, we know that in the natural history of COVID-19 infection, the virus itself disappears typically before the 11th day of infection. One is no longer infectious. One cannot spread the virus to somebody else. But the PCR, which can pick up a remnant RNA from the dead virus, or can actually be positive for up to 6 weeks. There are some reports which have shown even positivity at 12 weeks. And so many times, as a clinician, dispelling these myths, you don't know the number of times I have to get on a phone call with the president of a resident welfare association to explain to them that please do not insist on someone who has been found to be sick, who has already finished 15 days of treatment or isolation, to get a negative RT-PCR report, because that prolongs a lot of suffering, that gives you a lot of false positives, which actually cannot be interpreted as ongoing infections.
Sir, I think the next question I have is, a lot of people, after recovery, they have, you also mentioned this some time back, that, they have breathlessness and a lot of, is there anything that can be done for such people, to hasten the recovery process, some exercise or,
Actually, this is a very important question. If we can go back to slide number 6, please. Yeah, I keep coming back to this slide because it helps. It gives us a model as to what might be happening in this. See, whatever it looks like, it does not look like COVID-19 is strictly or limited to a respiratory problem. It's not just a disease of the lungs. It really is showing multi-system characteristics. And there is an interplay between the virus and the immune system. there seem to be elements of a type 3 and in some cases type 2 hypersensitivity reaction. Obviously, the science is evolving, and we are all learning about the pathogenesis on a daily basis. But 2 points I will highlight. Number one, clinically, what I have found is that you cannot look at COVID-19 as a 2-week illness. You have to think of it as a 6-week problem. There have been several cases, including patients I myself have been involved in the care of, who many times 2 weeks after they have recovered from, say, a hospitalization, and sometimes not even hospitalization, they could have stayed at home, they have a resurgence of fever, resurgence of tiredness, or some other complication. We know that people are getting myocarditis, which is inflammation in the heart. The COVID infection has been associated with higher risk of heart attacks, higher risk of strokes. And recently there was a discussion, there were a few cases where people had ischemia or necrosis, that is death of certain parts of their colon post-COVID. So, and we are finding some symptoms, presentations, which are presentations we see in rheumatological illnesses. We are seeing these patterns. We are also seeing a reduction in platelets, which some of the features of immune thrombocytopenic purpura, ITP. So this is a multi-system, it looks like an immunologically mediated infection after the initial viral phase. One thing which can help and actually helps people recover at least their lung function is respiratory physiotherapy. What that means is, many of you might have seen people use something called an incentive spirometer. This is just something you draw air in and there are balls in it. It's a very simple, relatively cheap device you can buy. So doing few things like, for example, blowing a balloon, taking deep breaths, beginning to walk, which helps your lungs expand. These have been, and taking the help of a physiotherapist, these have been shown to help. One of the other things which I think became popular because one of the politicians had put a video out was blowing a candle multiple times, because you need to take a deep breath in and blow out quite hard. So these are things which definitely seem to help and seem to assist with the recovery process. And I must say, I have been it has been heartening to see at least 2 patients who spent significant amounts of time in the ICU last year, who had been diagnosed with lung fibrosis, which is permanent scarring of the lung, and who at the time of discharge, after spending almost a month in the ICU, had to be discharged home on oxygen, continuous oxygen. I'm really excited to have seen their recoveries. One of my patients actually, he recently went for a 7-kilometer run. So there are positive stories coming out of this too. But respiratory physiotherapy definitely assists.
Yeah. So 2-part question for you. There's a lot of anecdotal evidence of people succumbing to non-respiratory causes like cardiac arrest or stroke, and so why does that happen? COVID-19 is effectively a problem of the lungs. So why do people succumb to these non-respiratory illnesses? First question. And the second one is, in a lot of cases, people appear to get better, and then overnight their condition just deteriorates. Why does that happen?
No, thank you. This is a very important question. I think SARS-CoV-2 is a respiratory virus. But COVID-19 disease is not a respiratory problem alone. It's a multi-system disease. So the SARS-CoV-2, so I will make maybe a comment about what I think might be happening at a pathogenetic level, but of course the science is evolving. Definitely, we are finding that this is not just restricted to the lungs. There are people who are getting strokes. There are people who are getting heart attacks. There are people with severe gastrointestinal symptoms. And there are other people with multi-organ damage and things like that. So and there are many patients who demonstrate features of vasculitis, which is inflammation of blood vessels. There are people who return with symptoms which are akin to a rheumatological illness, like rheumatoid arthritis. I'm not saying that this causes rheumatoid arthritis specifically, but rheumatological illnesses. What I think might be happening is, since the entry point of this virus is through ACE2 receptors, if we look at the distribution of ACE2 receptors in our body, they are definitely present in the lungs, but they're also present in the GI tract. There is also a soluble form of this. And I think what happens is, in the first week is when you have a lot of the virus replicating, there is antigenemia, that is, the spike protein might be getting into the blood. But around the second week, there is the formation of immune complexes. These immune complexes, or what I mean by an immune complex is, as the level of the virus rises, the body, there's an immune response, and the virus level starts falling typically by the end of the first week. But the antibody titer starts rising. Initially, our body produces something called IgM antibody, and then IgG. Probably a point is reached where the relative levels of the antigen and the antibody are fairly similar, that immune complexes form, and these go and deposit in multiple tissues. One of the things, at least that I'm learning about, is that the avidity, or how strongly the spike protein binds with the ACE2 receptor seems to be very high. So I don't know how well the immune system is able to discriminate between self and non-self. I recognize that whatever I'm saying right now is part of an evolving understanding of pathogenesis. Much of what I may say today might actually change, but I do think these are the mechanisms that are driving the post-COVID sequelae and the post-COVID phenomena. When I say post-COVID, I'm talking about the period of infection itself, post-COVID phenomena that we are clearly seeing all over the world.
Okay. Sir, there's been a lot of discussion on the airborne nature of this virus. A couple of big journals reported it, newspapers picked it up. What exactly does a scientist mean when he says or she says that a virus is airborne? Does it mean it's all around us, or what is the science behind when somebody says something is airborne?
Yeah, we have to understand the virus can come only from one person to another person, right? The source is only another infected individual. Now, how this virus is going from one person to other person can be by different means. One of these means is, when you are speaking, when you are singing, or when you are talking to somebody, how close you are to each other matters. Because the source is another infected person. If that person is very close to you and talking to you, obviously, as I am speaking, I am probably generating billions of aerosolic particles of various sizes. Some of them are bigger, some of them are small, and many of them will contain so many different microorganisms that are present in the oral cavity. Also in the virus, coronavirus. So it is the moment they are coming out of, since I'm wearing a mask now, they do not completely come out. Most of them are getting filtered here, but still there are some of them are escaping. If I don't have this mask, all these things are going to travel to some extent before they can actually fall. If some other person is within this range of these aerosol particles, they can inhale these same particles, and that is exactly that the virus wants to lodge itself, upper respiratory tract, right? Therefore, the most important route of transmission is in very close proximity where there is no ventilation, right? If I am sitting with a friend outside a garden, talking to them, even if there are so many particles coming out, they are getting diluted out. They are not, very small number can reach, and therefore the chances of infection are very small. So the close proximity is one important aspect, and confinedness without air, air movement or ventilation is another important reason. So therefore, it's very difficult. And the third important parameter is what is the viral load that is present in the fluids, oral fluids, right? If I'm again in the peak, I will have more virus particles that are packaged with these aerosol particles, but not in the early phase, not in the after phase. So there are additional factors, humidity, temperature, many other things also influence. But this is the reason aerosols are the most important way viruses, especially coronavirus, is transmitted from one person to the other. So the most important thing is to protect yourself. Both person A and person B, both should be wearing masks. That will cut down the transmission significantly, right? And having said this, I should also mention that your body is designed to actually defend yourself against such kind of aerosolic organisms. The virus is, where is it going to, land? It is going to land on my nose respiratory or mucosal membrane or throat mucosal membrane. It's not directly exposed to the virus. The ACE particle receptor is not waiting there for the virus to come and attach itself. It is actually covered with a mucous membrane, right? The virus is more likely to be trapped into this mucous membrane or in the mucus layer and eliminated, get removed. That's what happens. Therefore, it's not that I'm living in the same room. Some people are infected, some people are not infected. Why that happens? There are different reasons for this. So there are multiple layers of defects. So every single one virus particle, landing somewhere doesn't mean anything. But repeated exposures, the amount of virus density, all this matters. So therefore, each of these factors should be minimized. The best way to minimize them is aerosol. Using a mask, not one, everybody.
And maybe just to add to that, and I completely agree, mask is a very useful tool. Also, increasing ventilation.
Ventilation, yes.
That is, whenever one is in open places. I've actually, when COVID, in fact, the first set of cases I saw of COVID in May of last year happened actually following a closed room board meeting at a company, where it was a reasonably sized room, but it was there were about 12 people in that room and not very good ventilation, and so it's almost 10 out of 12 people got infected. So we having such meetings, for example, in a place where there is enough distance between people, where people are wearing a mask, and to the extent possible where you can open windows and allow cross ventilation, or have a meeting or meet people outside. Yes. In the open, where there is air is moving around. That definitely reduces risk of transmission.
So a lot of questions that we received were about the vaccines, and sir, so this is a very important aspect to control the spread of the disease. So first and foremost, with all of these new variants that are emerging, are the current set of vaccines that are available going to protect us from these new variants of the virus that are coming up?
Yeah, again, this is a very difficult question to answer. See, most of the vaccines are not like drugs. Developing drug resistance is much easier because drug is very small molecule. Whatever it is targeting, the surface area is very small. But when you're talking about vaccine is a protein most of the times, and it's a very huge molecule. So therefore, even if there is a small mutation that that, let us say, reduces the interaction to a large extent, the protein is so huge. So the immune response generated against this protein will have multiple target regions on this protein. The virus can escape from one of them, but not from the other, right? In other words, the protein what I'm using will have multiple targets. Let's say A, B, C, D, F, G, H, for instance. Virus can escape from A, but not from the rest of them. Or it can escape from B and E, but not from the rest of them. So usually developing a resistance against vaccine is not an easy task. But number one. Number two, even if there is a compromise, let us say a good immune response without virus escape is 100%. Now I have a variant. the effectivity dropped to 50%. It doesn't mean anything at all because this 50% is good enough to protect. A threshold value is what is important. If the protection, the vaccine induced in my body is above certain limit, whether that is, let us say that limit is 20, for instance, 20% protection should be there by the vaccine. But the vaccine actually established 80% protection. That means I have enough cushion to protect me. Against a variant, it may not be 80%, 100%, it has fallen to 40%. Still, it is protecting me because it is still above 20. Therefore, vaccines, the threshold of vaccines that provide to you is much, much higher. So usually, compared to an antiretroviral medicine, antiviral medicine, a vaccine gives you much broader range of protection. So it's not easy for the virus to escape from these vaccines. But again, at the same time, don't forget, we are talking about an RNA virus. Unlike DNA viruses or bacteria or many other things, RNA viruses have a natural tendency to generate enormous amount of genetic diversity. Therefore, in future, especially given the massive level of vaccination that we are giving, more and more escape variants might emerge. Those variant viruses are selected exactly because of Darwinian selection, and they will accumulate more and more. So the vaccine efficacy can drop from 100% to 50%, 30%, 15%, 10%. This is possible. So as of today, the virus hasn't really mutated to that extent that we have to worry whether these kind of vaccines are really useful. They are still useful because the gap is very, very huge. So right now, all the vaccines, by and large, to a large extent, they are very effective. Except against the South African, even there is only about 50% loss. So still that should be protective. But that doesn't mean in future, more viruses are not going to emerge variants. This vaccine efficacy may not be compromised. We do not know, but at this time, that is not a serious problem.
Okay. So another thing that leads to a lot of fear in the people is that these vaccines have been developed in record time. I don't think in any other disease there has been a vaccine that's been developed this quickly. Is it possible that there may be some long-term effects that might, of side effects of the vaccine that might come up after a year and a half?
This is a very important question. Actually, you have to understand, vaccine development 30 years ago and today is not the same. In this last 50 years, so the technology improved so much. Think about computers. Computers of 30 years ago and today are the same. There is so much difference in their design, in their speed, in their memory, in their processing. Same thing happened to vaccine technology. Today, you can generate a vaccine at a very, very fast rate. The question is not about the time taken for vaccine development. The question is about validating. Evaluation of the vaccine is what is important. That I cannot reduce. That I cannot compromise. But this is a very exceptionally dangerous or harmful or in exigency situation. There are people dying in thousands and lakhs. We cannot sit on these protocols of doing phase 1, 2, 3, 4, the same way we have done to other vaccines previously. So there are two things here, vaccine production and vaccine evaluation. Vaccine evaluation time I cannot reduce under any circumstance, but vaccine production can be done today at very rapid pace. That's not an issue at all. Therefore, what happened here is why people are skeptical about this is not about vaccine production. It's the problem with vaccine evaluation, right? Some of these people have developed, they have done 1 and 2. There are so much of controversy that the protective efficacy is evaluated. So there is so much of controversy. So we have to look at it two different ways. We have to understand this is a very exceptional time. Therefore, do you want people to die or do you want to take a risk? Cost and benefit effect. You have to understand this. At the same time, as far as possible, simultaneously, you cannot compromise on the second part of it. Vaccine evaluation processes. You can give these vaccines, but clearly, openly tell people that these vaccines haven't been evaluated the right way. A coronavirus is really not a serious challenge. Every single molecular biologist can make a vaccine to this virus. It's not a challenge to make a vaccine against coronavirus. It's not malaria. It's not tuberculosis. It's not HIV. They are very difficult. None of these people who are making vaccines today will go anywhere near them. They are real challenges. Coronavirus is no challenge at all. The problem with coronavirus is the scale, massive scale at which it is spreading because of its unique molecular properties. Therefore, I am not worried at the speed with which the vaccines are made. That is true. Any vaccine, any virus like this comes tomorrow, we think the same speed. But the evaluation process requires its own original time. Because of these very special conditions, we have to measure cost and benefit effect, and we have to understand this. But the only problem here is we should not hold it from the people. We have to openly admit this is the compromise I am making because of this reason, but we are parallelly doing studies. If you do this, I don't think there is anything wrong with corona vaccines. All the vaccines are very good. All the vaccines will give you protection. Please take vaccines.
Okay.
I want to second that and re-emphasize what was told. This is an exceptional time. At this time, in not just my assessment, but in the assessment of most people, the benefit far outweighs the risk of taking a vaccine. Secondly, questions of splitting hair about which vaccine is more efficacious than the other are in some ways not as relevant at a time of crisis like this. I definitely support taking vaccination. But I also agree with Professor Ranga, we have to be open and have a open-minded and learner mindset. Many things we may discover, but it's important to keep learning as to what might evolve. In my personal experience, I will say that the percentage of people who I'm seeing, and this is you can say this is largely anecdotal, but the percentage of proportion of patients who have taken the vaccine and gotten COVID is far lesser than the proportion of people who have not taken the vaccine and gotten COVID. The second thing is also that, yes, it is true, the vaccine may not be 100% protective intervention. Nonetheless, it looks very clear that those who receive the vaccine suffer a far milder illness than those who don't. So definitely this, I would encourage all of you to take the vaccine in case you haven't taken the vaccine.
Sir, on a related note, recently the government announced that they increased the time span between the two dosages of one of the vaccines. Does the science support this?
Oh yes. Can I have my slide, please? I have a schematic for this. Here, see what happens here is the following. Yeah, what is shown here is, this is where, let us say, you are given a vaccine first time. That is the first vaccination, and this is the immune response. Obviously, the vaccine, what enters the body, elicits immune response, that is antibodies, also T-cell immune response. Forget about T-cell immune response for the time being. This vaccine effect will wane off with time, and how much time it will take depends on many factors. But usually, in a case like corona, recombinant proteins or RNA, mRNA vaccines, they elicit such a response maybe up to 3 months to 4 months. Ideally speaking, if I have full control on this vaccination process, I should my second booster or second vaccine dose when it completely comes down to 0. That is where I would like to give, not here when it is in the peak. The reason why I have to do that is I want from the first vaccine dose an immunological memory to be established. I don't want all B cells of all types to be present when I'm giving my second booster vaccination. I want all of them to go. Here at this phase, there is immunological memory. Those cells are much better, higher quality B cells, which make antibodies. Here, it is a complete cocktail of so many different kinds of B cells. I don't want all of them. I don't want to activate all of them. I want to wait until this time when 99% of other cells are eliminated, die because they are not necessary. Now, if I give a booster immunization here, now the kind of immune response I can elicit is going to be much higher quality, much higher magnitude. And here I have IgM and here I have IgG. IgG is the much important antibody that I need for my protection. So the second booster vaccine should be given here. So what is the distance between the first booster by the time when it vanishes depends on many factors. Again, it's not one factor that can define. In case of coronavirus, we did not have time to estimate this precisely. So, but there are already a few limited studies. All of them show that the distance between these two should be minimum 3 months. Therefore, up to 3 months, there should be no problem at all. Even if you are giving a book, vaccination after 3 months, still it should be good. Because the immunological memory, what is established here, usually should stay for a few years. In many cases, okay, here we don't have time to understand about coronavirus. Therefore, once the immunological memory is established, it's not going to vanish so easily. It is going to stay with you for a long period of time. So ideally speaking, a booster should not be given at 1 month or 2 months. My opinion is 2 to 3 months is the right time as far as possible. So you don't have to worry that you are delayed. Even if it is delayed beyond three months, still it should be fine.
Okay. Sir, and one point that a lot of people asked us is, in between these doses, or even before the first dose, if you actually come down with COVID-19, what's that window period for which you should wait before you can take a vaccine?
I think extending the logic that Professor Ranga gave, it's the same logic. I think it makes sense to wait about 3 months, and that's consistent with the most recent ICMR guidelines as well. I think it makes sense to wait about 3 months before you take the vaccine again. I also want to emphasize that it looks like even a single dose of the vaccine is beneficial. But I'll just take a minute to provide a psychological perspective. See, as members of society, what happens is one sometimes vacillates. No, not as an individual, but one can move between vaccine hesitancy and vaccine urgency, where at one end of the spectrum you are worried what is the potential harm of taking this in the future, and a sense of urgency. Oh my God, there is scarcity. I really need this. I would urge whoever has received a first dose should know and feel somewhat reassured that even a single dose does help. Secondly, those who have received 2 doses, it's wonderful. It does look like if they get infected, which does happen, they're likely to have much milder infection. And the 3-month interval between natural infection, resolution of natural infection, and the next dose of the vaccine, or the first dose of the vaccine, or 3-month interval between 2 doses of the vaccine seems to make sense.
Okay, sir, we're moving towards the end of this session. One question that a lot of people asked is, some vaccines are different from others, like smallpox, measles. These vaccines, you take one shot, you're protected for life. But that's not the case even with the coronavirus vaccines. It's not enough. Why is it that some vaccines are so good and some are so difficult to?
Yeah, can I have my third slide, please? This is a very important question again. It depends on how your body is organized. See, here is the schematic I would like to draw your attention to. I classify this body into 2 compartments: mucosal compartment and systemic compartment. What is a mucosal compartment? Starting with mouth, upper respiratory tract, lower respiratory tract, lungs, and the gut, stomach, intestines, rectum, and vagina. All of them: mouth, nose, lungs, intestine. No lungs, that is also part of. Actually, lungs come under systemic compartment. Intestines, rectum, all these things fall under mucosal compartment because 2 important reasons, or 1 important reason. These organelles or these linings are already having billions and millions of different microorganisms. That is, there you have tons and tons of bacteria, funguses, yeast, viruses, whatnot. They are all lined with that, including lungs. At one time, people thought lungs don't have microbiota, microorganisms. Now we know that they have microorganisms, not to the same extent like in the mouth and nose, but still they have their microbiota, microorganisms. Because of this reason, the body is exposed to the environment. That is the reason the microorganisms colonize there, right? To protect that, the body has multiple mechanisms. One of them is to trap the microorganisms and remove them. That is the main purpose of the mucus. Therefore, it is called mucosal compartment. Because there are so many tons and tons of microorganisms already present there, the immune system main role is to ensure two things. These are all friendly microorganisms, except when something like a dangerous influenza virus comes or when a dangerous coronavirus comes. Usually the virus organisms which are present there are friendly organisms, they are necessary organisms. But there are also opportunities. Therefore, the virus or the body should understand this and they have to control these microorganisms. So there is huge number of natural microorganisms present in the surfaces, and because of this very large number of microbial load, the immune response can only be temporary. It's something like in a canteen in a railway station. A person who is working in the railway canteen cannot remember faces because so many thousands of people come and go. It's not like a small institute where there's a small canteen. There the worker, same canteen worker, remember everybody. Right? That is systemic component. So here, mucosal response cannot be enduring because of this huge microbial load. So it can be only temporary. This is the problem with mucosal vaccines. Like coronavirus, we cannot establish very strong mucosal immune response because of this natural microorganisms already present there, like influenza coronavirus. The other problem here is you have IgA antibodies that is most important for protection, neutralization on the mucosal surfaces, not IgG. IgG is also present, but IgA is the which is most important. When you look at systemic compartment like brain, heart, everything else, heart, liver, kidneys, blood, spleen, all of them, there is not only a single microorganism present in these organelles. They are completely sterile. There is no microorganism here. Therefore, if there is any by chance, if any microorganism enters this zone which is sterile, it's like a defense area. You know, if somebody goes to MG Road, nobody worries about this guy. But if somebody enters a highly contained zone, military zone, it will be immediate serious security threat. That's what happens here. Like TB, chickenpox, measles, these are all systemic infections. Therefore, their presence is immediately understood by body as serious danger. Therefore, they develop very strong immune response and very high quality IgG response, right? So when you are giving systemic vaccines, all the coronavirus vaccines were systemic vaccines, they elicit IgG immune response. Because these lungs are a part of, by mistake I put lungs and mucosal, actually lungs belong to systemic compartment. So when you are giving systemic vaccines, those vaccines which are injected into your muscles, they elicit IgG immune response. They can protect lungs from getting into severe disease, but they cannot stop coronavirus coming and lodging itself again. In other words, systemic vaccines cannot stop reinfection. But the most important thing, they can protect lungs. That is the important function of systemic vaccines. But if you want to really stop reinfection, you need nasal vaccines. Systemic vaccines cannot do that. Systemic vaccines protect you from disease, but protecting from infection is not their job. Okay, so that is the reason systemic vaccines have a limitation. They will not stop reinfection, but that reinfection is not going to be serious because your lungs are protected, which is much more important.
Okay. Sir, lastly, it looks like a third wave is inevitable. What would be your advice to us to ensure that we are better prepared for it? There'll be of course a window period till we reach that, till it starts picking up again. From both of you, what is the one word of advice that you can give us to protect ourselves and prepare ourselves better?
Yeah, whether that is first wave, second wave, or 80th wave is immaterial. It's a respiratory virus. It spreads from human being to human being by aerosol droplets. This can be stopped regardless of whatever the genetic content of the virus, just by simple COVID compliant behavior, wearing masks, washing your hands, and all other necessary requirements. Vaccines are not going to be a solution. This is very important thing. You cannot make vaccines and immunize all these people. And if you do that, there is an inevitable second problem. The virus can mutate such a way that it can go against the vaccine induced immune response. You cannot come with more and more vaccines. You cannot vaccinate all these people. Maybe rich people can get these vaccines any number of times, but not regular people, not poor people. Right? Therefore, vaccines are not a solution for any of this respiratory viral infection. Therefore, the only way to stop this virus is COVID compliant behavior. Until the antiviral medicines emerge, but that's not going to happen next 5 to 10 years. So this virus will go around for some more time. It is going to generate natural immunity, herd immunity, either by natural way or by vaccine-induced way. Or it will adjust itself ultimately at one time, it will vanish. Like many other previous epidemics have done, Black Plague of Europe did not kill everybody. It eliminated 1/3 of the Europe population, vanished. Similarly, the previous SARS virus hasn't killed everybody. It went around for 2 to 3 years time, killed a million, 10 million people, and it vanished. Similarly, this virus also will go around for some time. There are two possibilities. This virus can go around for some time, vanish, never to come back again. That is one possibility. Or it can become much down-regulating its own pathogenesis, become more friendly to human beings, less pathogenic, and keep circulating in the population. That is the other possibility. But I believe the first thing is most likely to happen. That is my personal opinion. But I have no specific reason to believe either one thing is going to happen or that thing is going to happen. But the only way to protect ourselves at the point of time is COVID compliant behavior.
I'll just add to that a few systems level things that we can do. Number one, India has a very large number of people who have multiple comorbidities or other vulnerabilities. For example, our rural population, and we know this from the history of previous influenza pandemics, and there are many lessons to be learned from influenza. Is that influenza did not remain just a urban problem, and we are seeing COVID also spread to rural areas. So number one, we have to put in place things that strengthen our primary and public health system. What do I mean? I don't mean something nebulous. What I mean is, first of all, we have to promote COVID appropriate behavior, as Dr. Ranga said. Second, we have to be careful about super spreader events. One of the things which triggers, and there can be debate, but one of the main things which happened between January and May was there were elections in India, there was the Kumbh Mela, there were other events, there was Holi. So we have to be very cautious about potential super spreader events, and we cannot let our guard down. The third is the extent to which we can expand our vaccination coverage is going to help. So whatever efforts we can make. And the fourth, very importantly, is that in our management, in our response, our public health response to the first wave and now the second wave, there have been innumerable and very valuable lessons learned. For example, when we know, for example, an early indicator of the next wave is if you just listen to stories from the field, for example, at primary health centers or at labs, you get the signal that the test positivity rate is rising, and that happens well before it reaches a peak point. So we have to keep our eyes and ears open to these events and take certain precautions well in hand or well in advance. First of all, if COVID care centers, for example, which are being opened now, if they can be opened very early in the course of the third wave, if it can be recognized and opened, this will de-stress the tertiary care centers, the hospitals. Second, oxygen, which became a crisis. If there are mechanisms put in place for early production and procurement of oxygen so that there is no oxygen shortage crisis, then that is something which will help. If the third thing is, of course, essential medications and access to essential medications. If these can be procured well in advance through a concerted and coordinated effort, which anticipates, then we can hopefully prevent some of the tremendous death and destruction that a third wave could bring about.
So on that note, I'd like to conclude this program. I would like to thank everyone who wrote in and asked us these questions that we posed to our experts. I would also like to apologize if you wrote and we could not answer your question. Please feel free to write to us at illuminati@jncsr.ac.in, so that if there are any more burning questions, we can, if too many people have the same questions, we can perhaps conduct another session. And I would also like to thank our experts, Dr. Ramakrishna Prasad and Professor Udaykumar Ranga. Sir, I think you have something.
Yeah, I just wanted to make one point. See, living through a pandemic like this it takes a tremendous toll on our psyche, on our mental health, and it can be very traumatic. So one of the things is there are several helplines, including one from NIMHANS, Bangalore, which are free helplines. Um, Please, if you're feeling sad, if you're feeling scared, if you're feeling traumatized, and if you're feeling isolated, because these are all things that we as human beings feel, please reach out. And it's important that we take care of our mental health as much as we worry about the virus and the vaccine and other things. I just wanted to leave that message.
Thank you so much, sir. And thank you all for watching. Please stay safe and take care.
Thank you.
Thank you.